Hi, everyone. My name is Michael Stewart. I am the Director of Education at the OI Foundation. I want to welcome everyone here this evening to a OI research update with the two BBDC researchers. Before we get going into today's meeting, I want to remind everyone that, like other OI virtual sessions, this session has live captioning for those who would like to use it. As my colleague just put into the chat, if you want to go to the live transcript button under show subtitles, you'll be able to view that there. Also, we will be recording today's session and posting it afterwards to the OI Foundation's YouTube page and to our website. So be on the lookout for that as well. Like other OIF virtual sessions, this session is not telemedicine, which means that while we want to hear from you, and we welcome questions from attendees and in the chat. And please, if you think you want to ask a question, please go ahead and ask it. We just want to remind people that our medical professionals cannot answer or provide direct medical recommendations or help to individuals on this call. But if you're not sure about a question, feel free to ask it to one of the OIF staff members on the call, and we can rephrase it in a way that is more appropriate for today's purposes. Also, so as everyone already knows, the topic of today's session is going to be looking at research being done around mental health and OI and pain. We want to just remind people that today's session will be focusing in on current and new research projects around that topic. If you are a person looking for specific recommendations or resources for mental health and OI, we're going to put into the chat in just a few moments some resources that OIF has already made around these topics, because we know that particularly in the past year, it has even more elevated the importance of maintaining our mental health during this time, but even just beyond that, the importance of mental health. So please, don't hesitate. Also, we'll put into the chat a link to Bone Link at oif.org. That is the foundation's email if you want to get in contact and ask us any questions. With that being said, I want to now introduce our two speakers today. First off, we have Dr. Reid Storch. Dr. Storch is relatively new with the Foundation and the Brittle Bone Disorders Consortium. He is a professor at Baylor College of Medicine in psychiatry and behavioral sciences. And he is also the vice chair and head of psychology and co-directs the OCD program at Baylor College of Medicine in Houston, Texas. Dr. Storch, thank you so much for being with us here today.
That's great to be here. Thank you.
Yeah. Also, we have Dr. Reid Sutton. So if any of you have attended a past OIF virtual or in-person conference, or particularly any of our events in Texas, you have very likely met Dr. Sutton. He is someone with his leadership is incredibly valued here at the Foundation. We're very lucky to have his long years of dedication and service to our community members. He is a geneticist at Baylor College of Medicine, in addition to being an administrative director and principal investigator at the Brittle Bone Disorders Consortium. Dr. Sutton, thank you so much for being with us.
Great to see everybody.
Yeah, and so I actually want to hand it off to Dr. Sutton first. Oh, by the way, Dr. Sutton has a great OIF t-shirt on, so I want to thank you for that. Excellent plug, Unbreakable Spirit. We love to see it. We love to see it. Dr. Sutton, I wanted to hand this off to you first because you wanted, I was wondering if you could potentially contextualize why we are here this evening talking about mental health and OI.
Absolutely. Thank you so much, Michael. So I think, as we often talk about in medicine and science, that, it's often a very slow build, which I know can be frustrating for individuals and families, but that's really the reality of the way that we learn most new things in science and medicine. And so obviously, really this all starts back with the OIF, and the OIF from its very inception with wonderful leadership and staff with a great commitment to advancing care and improving the lives of individuals with OI. And part of that I have been fortunate to be involved with was the start of the linked clinical research centers that, again, was started and funded by OIF over 10 years ago now, to again understand what the natural history of OI was, or what individuals with OI experienced across their lifespan. And that certainly included some information on things like pain and mental health. The OIF and other investigators such as Laura Tosi have been instrumental in looking at survey of adults with OI and trying to understand some of these aspects with the adult natural history study. And then again, based upon all of these things that the OIF has engaged with the linked clinical research centers, adult natural history study, and then other outreach and educational efforts through the OIF, we were fortunate to be able to get funding from the National Institutes of Health to be one of a couple of dozen rare disease clinical research networks. And it is in the first round of funding that we've received about 6 years ago. Again, part of what we proposed to do was to do a pilot study to look at various patient-reported outcomes tools that could, again, help us understand things like pain and anxiety that were identified by OIF constituents, as well as people on the OIF Medical Advisory Board, as being important domains or areas to address for women, for individuals with osteogenesis imperfecta. And so based upon that pilot study a couple of years ago that was done through the Brittle Bone Disease Consortium, we worked with our great colleagues here, including Eric Storch, who you're going to hear from in just a moment, to propose actually a more detailed study to look at, again, things like pain, anxiety, mental wellness, and ideally, of course, to develop interventions for those issues. And so we're fortunate that Eric is principal investigator now on this supplemental funding from National Institutes of Health, from the National Institute of Mental Health, that we'll be able to, again, kind of learn more about these issues and hopefully help address them in individuals with OI.
Great, Dr. Sutton, thank you so much. So I was hoping, I really appreciate that introduction, but I want to actually go in and ask you both a little bit more about yourselves. So I kind of gave your bullet points of, what you are doing now and your relationship to the OIF in broad strokes, but actually could both of you spend a few moments to just kind of introducing yourselves to our community and how you came to focus on people with OI and working with the BBDC.
Sure. So again, as I've mentioned, I've been fortunate to be involved with the OI for many years. During my training in genetics and early career, became interested in OI and other skeletal dysplasias, and so have done a lot of work, including working in our skeletal dysplasia clinic, providing care for individuals with OI and other skeletal dysplasias. And so again, it's been really kind of great in working with the OIF on, again, linked clinical research centers, medical advisory council, and other sorts of regional and national meetings, as Michael has mentioned, so that I can learn from you guys to kind of improve what I do here for my patients with OI. So I've been, again, kind of had a great relationship with OIF for many years and have very much enjoyed it.
Great, thank you.
Yeah, and I'm, sort of, very pleased that paths converged to this moment. So I'm a clinical psychologist by trade, and early in my career, I had this kind of dual focus. One was on more pediatric psychology, in particular involving rare diseases like Barth syndrome, glycogen storage disease. But concurrent to that, I also did more traditional work, especially within obsessive compulsive disorder and anxiety disorder space. So as my career kind of went forward, I ended up, moving towards the latter as opposed to the former. And so, fate had me become a Texan. Fate further brought Reid and I together in a non-OI grant submission that unfortunately the reviewers just weren't sharp enough to realize the brilliance in that one. So we didn't get funded there, but shortly after, there was some feedback that said, hey, here's some opportunity to re-engage and connect on kind of mental health aspects within brittle bone. And so we put our heads together, together with a number of great colleagues, including Sophie Schneider and others, and of course in partnership with the OIF to put together a supplement where finally we got some of the right reviewers to kind of see the merits of this and the importance of this, and really building upon some of the prior work to hopefully expand us, to get a bit more comprehensive information, both on the nature of things, but what we can do when we have that information thereafter.
Great, thank you both so much. So can you describe a little bit, like, what is this research project in more concrete terms, and how are you going to gather information on people?
Yeah, we're really excited about this, and one of the parts that, well, there are a lot of parts I'm really pumped about, but one of them is this whole notion of the researchers don't know that much. We might know some methodology or how to analyze stuff, but it's really all about talking to folks that live this day in, day out, to get their perspective, and then taking that information from the families and individuals, and then using that to further inform what we're looking at as we move forward. Now we're really fortunate that we have an incredible infrastructure. So partially with the OIF, partially with the natural history study, kind of a geographically distributed consortium at play. And so together, it really positions us well to conduct a multi-step research project that will span the next 3 or 4 years. So our first step, which we just opened up, and it's been, truly thrilling, because the demand and the participation has just been positively overwhelming, is to conduct these qualitative interviews. So to sit down for an hour via Zoom, and just to ask questions. What are some of your priorities in terms of understanding mental health issues? What are some of the challenges? What are some of the experiences you have with providers when you've tried to access mental health resources, whether it's with a physician, a non-mental health provider, or a mental health provider? What are some of the areas you think there needs to be research conducted? But really just a conversation and taking that information from both youth who are affected with OI, adults with OI, caregivers of someone with OI, whether it's a partner, a parent, whatever, and then getting some of our expert clinicians as well. But kind of taking these 4 sources of information and letting them converge to get a sense of what we want to do in the next step, which is develop further a quantitative battery that allows us to really tap into some of these aspects. For example, understanding what some of the mental health seeking experiences are like, or being able to tap into some of the work that Dr. Tosi and others have done that really try to investigate not only kind of the incidence of mental health problems, but what are some of those predictors or resiliency factors that may kind of support or put individuals at risk. So we'll include some of those questionnaires within the natural history study, but also develop a more comprehensive assessment in a smaller group of people where we can really more deeply explore some of these challenges, priorities, needs. Collectively, our goal there is to be able to take that information and start developing resources that can be utilized in the front line, but also teach clinicians about some of the nuances or intricacies of working with an individual with OI. So we're hopeful with this multi-year supplement and this kind of participatory research framework that we're able to kind of partner on this and find out many, many answers that lead us to that point of being able to have more personalized intervention in this space.
Great, thank you.
One of the things that I think that Eric's team is also going to explore to some extent, at least particularly in these kind of initial phase of the listening, the interviewing and the listening, is not just kind of individuals with OI or caregivers talking about, their, again, kind of family member with OI, but also trying to understand kind of the bigger impact on the whole family and the caregivers. So how does having someone with OI in the family kind of, again, obviously how that impacts them is important, but again, how does that more broadly impact the family and understanding that?
Good point.
Got it. So one thing I'm thinking about too is particularly like why, so the Brittle Bone Disorders Consortium, or the BBDC, which is an acronym you're going to hear a lot this evening, why are they doing this research in particular?
Yeah, well, so Eric gave a nice version. I'll give that real unvarnished version of how we got here, maybe. So as I mentioned earlier, this, in the kind of a number of years ago, again, as part of the BBDC, we had proposed as part of our grant funding to pilot some patient-reported outcomes tools. So we use this term a lot in medicine, kind of patient-reported outcomes. Most of you probably would call this like a survey. So, it just basically is asking you questions about like, how do you feel? How does this impact your life? And these sorts of things. But we have to have a fancy name for them. So we call them patient-reported outcomes tools.
Okay.
But so we wanted to try to look and see, okay, are there patient-reported outcomes tools that could be useful to us, not only in the research setting, but ideally in clinical care, right? So if we can identify tools that, you could like have a survey that you could complete when you go to your, regular primary care doctor or OI doctor that could identify, red flags for the doctor or things that the doctor needs to address that they may not think to ask about during the clinic visit. What would those be, and would the kind of these standard measures that have been published in general, would they work for individuals with OI? And so again, with kind of the BBDC, also this included Laura Tosi and Jeff Krischer, who we worked with at the time, did these kind of preliminary or pilot studies to look at these patient-reported outcomes tools. And so there was information that, again, we've published out of the Brittle Bone Diseases Consortium that indicates that in individuals with OI compared to the general population, anxiety is higher, as is what's called pain interference, or how kind of pain affects what you're able to do on a daily basis. And so we thought it would be great to look at that in more detail. And most NIH grants are only for a short-ish period of time, usually kind of 3 to 5 years. And so we had to renew our grant and had to propose something new. And I thought it would be good to try to build upon kind of what we had found from those patient-reported outcomes tools. But the National Institutes of Mental Health saw through me that I wasn't a psychologist or a psychiatrist, and they said, this sounds like a good idea, but it needs a little more time back in the oven, and maybe you could get a psychologist into the kitchen with you to help bring this fully to fruition. And so, again, as Eric had mentioned, he and I had worked together on another proposal previously, and so I went begging to him to see if he would possibly consider helping us out with this. The NIH was kind of a little bit cagey about what they were going to do with this, but they said, like, why don't you go find somebody who knows what they're doing, come back to us with a new proposal, and we'll kind of see what we can do. And then, so Eric, Sophie, and some of his other colleagues did that. And again, we were kind of very fortunate that the National Institutes of Mental Health came back with, I think, probably better than any of us expected, with kind of essentially like a 4-year supplement to the grant. So I think we're very pleased with that. And so again, that's how the Brittle Bone Disease Consortium was able to get NIH, National Institutes of Health, to agree to help us. And I should say too that, one of the things, again, this like funding from National Institutes of Health, as I'd mentioned, with kind of our knowledge and understanding of medicine and science, that often is also a little building thing, right? That, everybody likes to give money to successful operations or successful ventures, and nobody likes to bet on a loser, right? And so NIH to some degree acts like that. But if you've got NIH funding and have an infrastructure, they're often more keen to kind of fund other projects. And so I think the fact that we had the BBDC was kind of one of the factors that encouraged National Institutes of Mental Health to add funding, to add supplemental funding. And I should also say that this is actually the first rare disease clinical research consortium out of the couple of dozen that NIMH has given any money to at all, right? So this is kind of their first foray, believe it or not, into the rare disease clinical research network, which I think is great. And hopefully, again, we can continue to build on that.
That is fantastic to hear. Thank you. And that is so exciting to hear, actually. I really appreciate kind of that more backstory. One thing this is making me think about, though, because you're talking about, patient-reported outcomes, is has there been any other work, whether they be studies, formal or informal, previous to this study around mental health and OI?
Yeah, so there's been some work, and as Reid mentioned, Laura Tosi did a great paper. I think, Mary, you were one of the authors on that, and it really did a good job getting a large sample of individuals to complete these patient-reported outcomes. And what was interesting on some of the measures, there was kind of elevations in anxiety and this kind of relationship between pain and anxiety. But on others, things were sort of smack dab in the middle. And I think, when you kind of survey a bunch of people, sometimes you see kind of a broad dispersion, but it didn't quite tell us, despite its strengths, where there might be hot spots or folks that we want to pay particular attention to, or the needs. And so that's where we wanted to come in qualitatively and really just talk with folks and listen, and sort of hear what some of those thoughts were, experiences, and suggestions for directions. And so I think this will help us be pretty comprehensive in hearing from multiple stakeholders to just figure out exactly where we want to go. What was particularly great about NIMH, and Reid, I didn't know that this is the first one. Pressure's on us now, but they gave us some flexibility to kind of look at where the information, or go where the information takes us, and that part's exciting. But I think that the marching orders are, hey, here's your chance to really find out a lot, publish like crazy, and so that we have that foundation in place, and then from there, we have that opportunity to say, hey, here are the needs. How do we start addressing those needs? And that's kind of chapter 2, if you will, of this project.
Yeah. So actually, on that note, so it sounds like, when you mentioned like chapter 2 about addressing those needs once they've been identified, even though I know obviously the study has not really happened yet, what are the tools or ways in which the results of the study in the future will improve the lives of people with OI? Because gaining more knowledge is great, but that is ultimately just a first step. is it like, what kind of tools will get made from this, ideally?
Yeah. So I'll throw a few thoughts out, and I will not that anyone would want to hear from, well, certainly me. I suspect they'd like to hear from Reid in a year, but it'll be fun to talk about this in a year or two where we have even more fleshed out ideas. But some examples would be starting from kind of educational materials for family members on what to expect if you have a child with OI, and sort of counsel for providers on things that you might be mindful of if you're working with OI, particularly if it's more of a local provider and not, an expert like, Dr. Sutton. But what are some of the aspects that you want to be mindful of? Another would be for clinicians in the mental health sphere. So how can we start educating on what are some of the challenges? What are some of the unique aspects of working with this population? At the same time, how do we tailor interventions that we know work to be sensitive here? For example, if we know that with adolescents, there's concern about appearance or appearance related issues, and great. How do we think about kind of addressing that in a way that's personalized? How do we think about taking pain-based behavioral interventions and again, making them more kind of attuned to specific needs? And then recognizing that we're not going to train massive numbers of OI, but we may not train massive numbers of OI clinicians, but how do we start developing that so that major cities have this? Because now telehealth is making things more and more accessible. So I think that would be another area, as well as utilizing technology outside of telehealth, but in kind of app-based form to be supportive. One project that we're working on right now with my colleague Sophie is developing on an internet-based cognitive behavioral therapy protocol for anxiety in kids with autism. So how do we take this, and it doesn't require therapist support. It's really recognizing that it kind of we can teach parents how to support their kids, or we can teach adults how to support themselves without having to go to a mental health professional. So sort of these several tiers of support that I could see emanating from this project, and unfortunately areas that we've been working in already. So we have kind of a foundation to really prop us up to try to move things forward a bit more quickly.
And even maybe kind of a little Eric's kind of talking about like a year or two down the road, but even like further down the road. So again, as he had mentioned earlier, the first phase is the listening part, but the listening part is going to inform changes to the Brittle Bone Disease Consortium natural history or longitudinal study. And so this will be somewhat unique as well, in that because it's part of the longitudinal study, we'll not only have this information about mental well-being, but we can link that and see how that affects other aspects of their life or vice versa. So if we look at, we can look at fracture numbers, we can look at mobility, we can look at what they report about, kind of, again, other things related to their OI that are maybe kind of more medical in origin, to understand things like who's at risk, right? So can we identify factors that we know that individuals are at higher risk for things like anxiety based upon, their medical experiences? How do those medical experiences influence their mental health, and vice versa? Eric had mentioned kind of resiliency. And so again, some of these, that really just means kind of what sorts of factors kind of are protective for people that are kind of at risk for mental health issues. And so, again, it may be that we could, through the longitudinal study, identify these other factors that, again, would reflect either kind of risk or resiliency.
That's very fascinating. So it makes me think about the kind of, when people use the phrase like mind-body connection in the terms of health, and how exactly you're saying, like, potentially being able to like spot those correlations, if that's even the right word here. one thing you're also making me think about is just how much it seems that this study and these initial sets of interviews, it seems like how much ground they're trying to cover. Are there certain topics that you are trying to hone in on or particularly evaluate in these studies within the field of mental health? Because it feels very broad.
Yeah, and challenge on top of the fact that we don't want to bore anyone, for too long, but keep focused. I think after an hour, it's just asking too much of anyone to sit on Zoom. But there are a few. One of them is really kind of their experience with mental health problems, whether it's themselves or their loved one, and what that looks like. What that looks like. Second is perceptions on things like the interplay between pain and behavioral health, and so sort of what that relationship is. Third area is really tapping into experiences within the mental health system, both positive and negative. And I should say, Michael, the goal of these interviews is not to be, like all the things that are problems, but it's really to have sort of a positive, resilient spirit here. So on that note, a fourth domain is really what's worked. Whether it's supporters, whether it's activities, certain things that individuals have tried. So we want to tap into that. And then the last point, without belaboring it too much, is what Reid hit on is understanding kind of the whole system, and picking up on that from the standpoint of OIF, but also just behavioral health too, and how this really kind of it affects not just the person who may be struggling with behavioral health things, but everyone around them.
Yeah.
We'll say too that the nice part about these qualitative interviews is we specifically call our interview guide a guide, and it's it's like you kind of take that long winding trail, and at the end of the day sort of where you get to, but it's a path, and you kind of follow where that conversation goes, with the idea that we really just want to listen and learn. And that will then kind of help us move forward.
Great, thank you. So in a kind of related vein, when we looking through attendee questions, we're receiving some common themes we're picking up was the sort of the seeming correlation or the prevalence, as Dr. Sutton also brought up, of seems to be like anxiety, depression, and particularly in our community, people using the phrase PTSD. I'm wondering if you could just spend a minute or so, if you could quickly define and explain from a clinical standpoint in terms of this study, the relevance of depression, anxiety, and PTSD.
Mm-hmm. Sure. So start with the definition, and then go to the relevance. So anxiety takes on all sorts of forms, and some are more kid specific, but if we start with the little ones, the kid specific form is separation anxiety, worry about separating from people you love. Now, kids and adults alike can experience a bunch of other types. Just generalized anxiety being sort of like a worry wart where you can't control it. Social anxiety, where you're worried about fears of negative evaluation, usually coupled with avoidance of social situations. You can have panic disorder, which is where panic attacks come out of the blue without a known precipitant, and then a lot of worry about those things happening again in the future. Some people will have specific fears at play, which usually, actually, most everyone has that. And it's not too common they become so problematic at play. We have obsessive compulsive disorder, which is still an anxiety-based condition, and lots of different types of that, but characterized by these unwanted, intrusive, upsetting thoughts, coupled with a behavioral response like a ritual, like hand washing, or straightening, repeating types of things. And then in post-traumatic stress disorder, It's really characterized by experience of some traumatic event or events that's then followed with intrusive thoughts about the event, various recollections that can come in a variety of fashions. This kind of physiological component, like you're always kind of on edge, you're easily startled, lots of nightmares, somatic complaints, which again covers all of these anxiety problems. And then behavioral avoidance, usually of things that kind of evoke the trauma. And then depression is, something that's common. In fact, all of these are quite common, but usually characterized by, depressed mood and kind of not enjoying stuff you used to enjoy for a period of a couple of weeks, and usually more than that. Now, behavioral health things are super common across everyone, whether you have OI or, just don't. So about at least 20% have a diagnosable problem at any given point. COVID's added on top of that. So I mean, we're seeing that, somewhere hit around that 30% range of kind of diagnosable problems, which just means there's something we got to pay attention to. And not to mention, there's just stress that's sort of a balance for everyone. I think the relevance here, you sort of hit on earlier, Michael, with that mind-body connection. We finally hit a point where we appreciate that mental health is as important as physical health, and that they are intimately intertwined. And if we don't attend to one, then the other is going to be affected here. So we know, for example, that in individuals with co-occurring behavioral health problems, that pain is more intense than someone who may not have those same problems, just as one example. We know that when you have mental health problems, you see problems with sleep come into play, and that sleep can have an interface with that relationship with pain, just as one example, as well as those behavioral health problems. And then even if we take out that kind of co-occurrence between mental and physical health, there's just the notion of, hey, we're here once, let's live our best life. So if you're sort of dogged by feeling depressed or anxious all the time, well, we got to do something about that. And we're at a point where there are good interventions that are available. We just need to figure out how to make them more accessible and personalized, so that they work as optimally as possible.
Great. Thank you so much for that really excellent, thorough answer. I think I and the audience really appreciate that. I want to jump to a different topic only because I'm trying to be mindful of the time. I want to ask a little bit more about the design of a study like this. So you talked before about you were going to be interviewing all these different groups, caregivers, I believe, medical professionals, children and adults, if I'm remembering correctly. What are the differences in assessing, say, adults versus children with OI? And my sort of third is, what about like teenagers or like adolescents? Is that a third group or one or the other?
Yeah, I know. I'm laughing. I went into my wife's classroom this morning. She teaches second grade, and one of the kids picked up that we had the same last name. She says, "Who do you think this is?" And the kid's like, "Oh, that's your father." Which I what? Can I leave now? So and there wasn't even a teenager. But I in part we'll see. I think from our teenagers, what we've seen from doing these types of qualitative interviews with other teenagers is that they're brilliant. Their perspective is so interesting, and while it converges with the perspective of parents, just as an example, they often have ideas that may be a little bit different, or because we're not going to tell their parents what they're saying, they'll disclose things, challenges with dating, for example, that they don't want mom and dad to know about, but we'll hear some of these things because it's important that we know it. And so I think part of the way we go at that first round is just try to be normal, human beings, accessible, friendly, When something's said, you just try to follow up on it. Of course, non-judgmental, but most of the time, people really enjoy having that chance to open up and chat about what's happening in their life. At the same time, we're so lucky. I mean, good Lord, if in some of our other projects we could have the response that we've had already in about a week, research would be really easy. But I think that speaks to, I mean, having that foundation in place. And even with the natural history study, furthermore, we have kind of that already well-tested, well-oiled machine to be able to include some questionnaires, patient-reported outcomes that allow us to prospectively follow folks and understand not just a one-time point relationship, but kind of what happens over a year or maybe 2 years to some of these variables, and what might be some modifying factors that predict a different trajectory for one person versus another.
Fantastic. Thank you. So I have one last question on sort of the design of a study like this, then we're going to go on to some audience questions. So the next one is about I think it's a qualitative versus quantitative question. So you talked before about how, these are interviews that are ultimately, you're literally trying to gather people's feelings instead of other BBDC research initiatives are about, these what feels like very objective measures, whether it be height and weight and dosage of various medications. You're interviewing people about their subjective feelings of experiences. How do you account for information being skewed or biased when you're designing the questions? And you said even before that there's not like a set, or there's some flexibility even in the interview itself. How do you account for bias?
Yeah, this is a challenge in qualitative research. And I think that the first thing I'd say is the qualitative leads us to the quantitative, which is kind of, we've defined it as, this is aim 1, the qualitative, and aims 2, 3, and 4 are all quantitative in nature. We thought that aim 1 was really critical to make sure that we were asking the right questions in aim 2 and 3 and 4. And so that was sort of the sequencing, having a very purposeful sequencing. I think the issue of bias is one we're always mindful of. So what we've done is we've spent weeks actually developing out the questions, asking input from stakeholders, including a number on the folks on this call, and really getting to a point where we felt comfortable that we were tapping into the questions that we wanted to hit at. Now, as we move forward, we audio tape the interviews, and then we transcribe them. And so from the transcription, we end up then using a qualitative data analytics system that is able to extract themes that come up on a repeated basis. And then we take that content that's associated with those themes to be able to kind of generate more or less a narrative of this. So at the end of the day, the information being spoken is really, those are the data. And then our analytic method is all about the frequency or the occurrence of those data, but it allows us a certain richness to understand things that's a little bit different than just a number. At the end of the day, what I like is this mixed method approach where we're able to get both and be able to not only generate ideas, but confirm those ideas from a quantitative standpoint over a period of a few years.
Great, thank you so much. So we have a few minutes left. I want to squeeze in some more questions. And if you have any questions for the speakers, feel free to type them into the chat, and we will try to get to it as many as we can. I want to zoom out a little bit away from just this particular study. These are some questions from the registration. One is, what do we already know about living with a chronic disorder? like OI, but not even necessarily OI, and its impact on mental health. Going backwards a little bit.
Yeah, Dr. Sutton, do you want to go, or I can, whatever?
I can give it a shot. Yeah, so we certainly know that having a child with chronic illness is not only kind of stressful for the child, but stressful for families. So if you look at things like parental conflict, or even things like divorce rate, those are much higher in families where there's a child with a chronic medical condition. And so we know that, you know, these chronic medical conditions not only impact the individual, but also kind of impact the entire family. You know, I think it really does depend to some degree on the disorder, and even kind of how the disorder develops. So I think, you know, one of the things that, you know, that you can see, I think, in many kind of chronic disorders is in conditions where, you know, it really is kind of a from birth sort of condition where they've been dealing with that kind of their entire life. I think that often is maybe a very different experience than an individual who is well for a period of time, and then in, you know, later childhood or adulthood develops a chronic condition, and that their perceptions of how that condition affects their lives can be different, again, depending upon the age of onset. So I think, again, in all of these things, obviously we see an OI to some degree and are analogous, but you know, how those specifically affect OI, again, is what we hope to learn more about.
Excellent, thank you. So I want to ask, it seems like, you know, as we're talking about the study, we've actually already gotten many compliments on for both of you. So I want to thank you both for being here. People are asking, do you have any suggestions for finding mental health professionals who understand OI? Do you have any recommendations or tips? This is very much veering away from the study, but I would be curious to hear your thoughts.
I think that's one of the things we hope to address. Is really the availability of clinicians with either some aspect of expertise or access to resources that can provide counsel and information. You know, there are different behavioral health interventions that really we know work, and so I think it's key that we're able to deliver them and deliver them with fidelity and personalized. And so there are some associations which really, you know, sort of advocate that, whether it's from a psychotherapy standpoint or the standpoint of, standpoint of psychiatry. One thought, from my own experience is that, professionals that have experience working with individuals with chronic illness are often able to kind of see parallels between different chronic illnesses, even if they don't have experience in OI. So thinking about that as you check out various profiles, if you're in a town with a institution like Baylor or UT or whatever of the 50 we have here, or somewhere else, that can be one way that you might be able to access that. The other is within your state, just thinking about telehealth as a potential resource. But overall, I think we do need to be better at improving kind of knowledge base for the average clinician that may not see folks with OI, and I think that's one of our goals today. Not just today, but with our study.
Absolutely.
Right. And I think, Eric, to circle back around to kind of what Eric had talked about, kind of two aspects. One is tools, right? Development of tools or some sort of toolkit We talked about publications, and I know sometimes people are like, well, I don't understand what that's doing for me in a medical journal, right? But I think, often, if there is a publication that, an individual can take, or, I can send to, another health professional to say, like, look, here's what's been published that works, right? Or here's the approach that one, should be taking, that again, that often can be very helpful in guiding the best care for individuals.
Great. Thank you both so much for joining us this evening. We are so thankful for your time with us to talk with us about this very exciting research. As you can probably both tell from the overwhelming response you've gotten for volunteers, our community is really wanting to engage in this topic. I can tell you from my experience as a OIF staff member and someone who's met many people across the country with OI, there are certain themes that come up consistently, and this is a topic that people always want to talk about. We are very excited for this work being done. To those on the call who have been asking about, are they still taking volunteers? It seems like, correct me if I'm wrong, we have filled all this. You have filled all the slots for volunteers. However, it seems like there are coming future stages, TBD, I believe, and we will wait to hear about what those are in the future. But we will let people know about what the future holds for the study. And Dr. Storch, Dr. Sutton, thank you so much. And to everyone, I hope you have a good evening. Thank you.
Thank you.
Thank you, Michael. Great to see everybody.